I'm going to ask all of our presenters to please come up to the front, including Dr. Hristov, who I would like to introduce to you as our local dermatopathologist specializing in cutaneous lymphoma. So we have two really phenomenal pathologists, dermatologists, oncologist, and transplant specialist. So we have pretty much almost everybody for you to ask hopefully some really good questions. This is your time to tap the brains of these absolutely brilliant clinicians. I'm going to run the mic, and we'll let them decide who's going to answer. You can ask any of them individually a question.
I have a question for Dr. Lin. I thought it was very interesting, the discussion that you did about the Sézary syndrome, the genetic mapping, and the study that you did. And I was curious to find out if they were doing any type of genetic studies of siblings or of offspring of the Sézary patients to see if there's some sort of genetic connection. Because I think you said something about there's a chromosomal fusions. I was just curious to see if you could provide a little bit more information on that topic.
Okay, thank you for that question. So the chromosomal translocation that we identified, the NPM-TIG2, was one that we saw in diseases that were diagnosed as CD30 positive lymphoproliferative disorder. So that's distinct from the Sézary. It looks like from our analysis of the Sézary syndrome, we didn't find any recurrent chromosomal translocations, but there were many abnormalities of genes that are involved in chromatin remodeling, as well as those that may be important in DNA repair, like P53 and genes that regulate the cell cycle. To date, I don't think there's any evidence to suggest a familial pattern of involvement of any of the CTCLs, including Sézary, but that's an important point, although I think last night we talked about the lack of risk factors in any of the CTCLs, and that does bring up the question, is there an exposure or is this something that occurs over time as people age? I know Dr. Koja Lenitoba-Johnson, who is here, and he's the director of our molecular diagnostics laboratory and spearheads many of our genetic analysis in hematopoietic neoplasms. He might want to also comment. I know he has questions for us too.
I have a comment and a question. So the comment is in response to the question from the audience. So it may be important in this audience to make the distinction between hereditary and genetic. So it's important to recognize that a lot of cancers have mutations, and these mutations are acquired. The patient is not born with them. This is very different from familial cancers that the mutations the patients are born with, and it only becomes a question of time in the evolution of the cancer that it develops. So I trust that a lot of you have read in the popular press that there are individuals who have mutations like the BRCA mutation, which predisposes them to breast cancer maybe, and ovarian cancer, and people can proactively do something about that. So those mutations are inherited. They're in virtually every cell in the body. Whereas most of the other cancers, the cancers that affect everybody else, the non-familial cancers, are referred to as being sporadic, but the mutations are acquired. They're only in the tumor cells. So it's kind of important to make the distinction between hereditary and genetic, because our current understanding of cancer today is that cancer is a genetic disease, but the vast majority of them, the mutations occur only in the cancer. So if we wanted to figure out whether a sibling or a parent had the same mutation that we may have detected in a form of cancer, that would be studying familial cancer. And very frequently there's little overlap between the genetic markers of those group of diseases and those that affect the population in general, the so-called sporadic cancers. Is that sort of something that people appreciate, the distinction that I tried to make? Okay, so that's my comment in response to the question. So here's my question to anybody in the audience. Maybe this would be more relevant to the talk given by Dr. Uberti. Would you say that there are prospects for CARS-like therapy for the treatment of CTCLs, as we've seen with great progress in the B-cell lymphomas?
So I think we'd have to identify a marker. As you mentioned, most of the CARs have been directed against the B-cell lineage and using either CD19 or CD20 as a marker with the transduction carrying a vector that targets that marker. So if there were a marker for the CTCL that we could use and integrate it into the viral particle, perhaps there could be. Having said that, CARS therapy is fairly aggressive therapy. Patients who get CARS therapy sometimes require intubation in the ICU for 4 to 5 days because of cytokine release syndrome. So the therapy itself has some phenomenal success, but is fairly aggressive therapy on par with almost a transplant. So I think it could be used. They have to identify probably a marker that could be used for the target, but again, it's pretty aggressive therapy.
Could you talk a bit about transformed large cells?
So I'll try and tackle this topic. With mycosis fungoides in particular, originally patients will have smaller cells in their epidermis in particular, but as the disease progresses, those cells transform into larger cells, and we look for those cells to be 4 times the size of a normal lymphocyte, and that's how we make the distinction. When 25% of the cells in a biopsy are more than 4 times the size of a normal lymphocyte, we make a diagnosis of transformed mycosis fungoides. Basically, it's thought to have a worse prognosis, meaning that patients tend to do worse with that, but the results in many studies are conflicting. So in some studies, patients do worse than in others. And those cases usually will express a protein, or often express a protein called CD30. And they will often require a bit more aggressive therapy. So if there's only 1 or 2 lesions, they can be treated with radiation therapy. If there are more lesions, sometimes we move into systemic or other treatments.
When we looked recently at 56 cases of advanced stage MF, meaning 2B or greater, for another study, it had nothing to do with large cell transformation, but so I have some data on that subset, and about 9% of those cases had evidence of large cell transformation. That, however, should not be extrapolated as a whole to the population, because again, this is a very small group, but that's a number I can give you because that's the one that we look at. I think that the one important thing for the audience to understand is that it's not always necessarily true 100%, but as a general principle, in lymphoma, the larger the cell size, the faster the lymphoma grows, the more aggressive the lymphoma is. That's why, there's such a emphasis on how big the cells are. The cells are smaller. That means they're a little closer to normal, and a little slower moving. The larger they are, the faster they're growing. Their control of replication is much more likely to be lost. And that's why people think that this large cell transformation really, may, logically be associated with a worse prognosis, because if the cells are growing faster, they are, more replicating, on a higher speed, then the prognosis presumably is worse. But we don't know for sure, but that's the rationale behind it.
I just have a comment about, I think there's a concern about transformation and lack of understanding. Certainly, definition is one, but clinically, I guess that's maybe a question that a lot of patients have. What does it mean? Or what do the physicians mean, or why are they concerned about transformation? In general, when we're following patients, they have patch, and generally these patients are early stage patients with patch and maybe thin plaques. We're treating these patients, for many months, and they're under control. When they develop a new tumor, so there's a real change in the presentation of their disease. They have a lump and it's growing faster. Those are the types of lesions that we're concerned about, this transformation. Now, we do see a lot of patients. One of the things that we do see in CTCL, and there is a subset that can be very aggressive, and we do see it, and that's, I think, the subset we need to identify for transplantation in the future. But there we're trying to define, is it histologically transformed? Biologically, sometimes, these, I know Dr. Porcu and we treat patients, these tumors are popping up very, very fast. Normally we're talking about following patients over months, and we see patients, 6 months, years, and we can see, we get concerned if they have more patches and plaques. But when patients develop a tumor in a short time, like a month, then that's when we're very concerned. And those are the ones that we need to know, is it transformed?
As I've tried to understand the potential efficacy of the various therapies for both early and later stage disease, I've been confused by a word or terms, so if I could come back to that for a second. So you have partial response and complete response, and as a layman, as I understood, talking about the appearance of either plaques or patches on the skin, when you're talking about that in early stage. One, is that true in later stage? And is there a difference in those terms used for CTCL and other cancers? Because it seemed to me like there was.
Great question. So let's talk about that a little bit. When the response assessment, so the definition of what kind of response a patient had, complete or partial, is dependent on all the tests that we do before treatment that can give us an idea of where the disease is and how much of it there is. In a lot of cancers, including most lymphomas, the way to do that fundamentally is based on a physical examination. So the doctor has to look at you, put your hands on you, feel the lymph nodes, check everything, and then what's called imaging, so CAT scans or PET scans. Okay, and each test has a slightly different way of measuring that, but in the end, the assessment of how much disease there is and how the response, how good of a response you have, depends on the sum of all those three things. In CTCL, that assessment is unfortunately more complicated than in most other lymphomas, because there is a component of looking at the skin, which really is absent in just about every other type of cancer, with few exceptions. In addition, the examination of the skin is complex itself, because we're looking at all these different type of, we call them lesions, right? So patch, flat, or plaque, thick, tumor, and so on. And then it's even more complicated because a lot of times the skin may not look completely normal to the naked eye and to the, to the examination, even if perhaps there has been a response. So the assessment of the skin is difficult, and then you have to look at the lymph nodes, and then you have to look at the internal organs, and then in CTCL there's also a component of looking at the blood. Of course, the blood is involved in Sézary syndrome, but it can be also involved in a more advanced stage mycosis fungoides without the Sézary syndrome picture. Unfortunately, the breakdown, all the different points of assessment for each one of those components. And we can go back to that slide that I showed, the skin, the lymph nodes, the internal organs, and the blood. For each one of those components, there are 3 or 4 parts that, the measurement of disease can be broken down into, so it kind of makes for a really complicated assessment, and that's why when we do clinical trials where the response has to be measured very accurately, or at least as accurately as possible, then unless you really are an expert in this kind of diseases, it's difficult to do that. Now, complete response means that when you look at the skin, when you look at the lymph nodes, when you look at the internal organs by CT scans or PET scan, and when you look at blood, there's absolutely no sign whatsoever of T-cell lymphoma. That's kind of a tall order, and that's why a lot of times these complete responses are, meaning you don't see anything, the rate is low. Think about, for example, that romidepsin or Zolinza drug that I mentioned. Overall, the response, if you any kind of improvement, beyond a certain cutoff that is decided, is considered a response. And if you count like that, 30% of the patients who were treated had a response, but only 6% of the patients actually had a complete response. Now, a partial response may still be valuable, because if you have, if your quality of life improves sufficiently with a partial response, and you can maintain that partial response long enough, why not? I mean, I think that's acceptable. But the complete response, it's important before the cure, right? I mean, I think that unless we really get rid of the disease completely, like Dr. Uberti was mentioning, then you're not going to see that flat line, on the long-term follow-up, that the disease is not coming back. That's what transplant does. Transplant allogeneic is good at cleaning up everything that is left over after the treatment. Does that answer your question? Okay, thank you.
So I have a question then that comes up a lot is, what kind of testing should we have done periodically as patients as we're going through treatment? Should we have blood work? Do we need CAT scans? Do we need PET scans? When should we have those kinds of testing done throughout the course of our life with cutaneous lymphoma?
I mean, the nature of CTCL, and is defined as a primary lymphoma of the skin, as Dr. Lim mentioned, we earlier on, these originate from the skin, so that's where when we see it, that's where it starts. So if a patient is in the early stages, I mean, in our practice, we examine the skin. I think as the disease advances, then it involves, and it extends on the skin initially, and then before it maybe involves the lymph node, and then also the viscera and the blood. So early on, I think skin examination is the most important point. We do routine laboratory tests in our clinics as more of a monitoring when we're seeing patients in return. But those who have limited skin disease, there's no need to do CAT scans or other PET scans. Now, I think if the disease does progress, and if we find based on a physical exam those lymph nodes, then that's when it's indicated to do more imaging. blood tests are always helpful, and that's really what guides us. I mean, it's a primary cutaneous lymphoma, so this is a disease that starts on the skin and evolves from the skin.
Something about research then, perhaps,
Please.
real quick?
Yep.
So we had actually a very nice discussion with a panel of physicians last night before the event this morning to kind of illustrate some of the things that are, that are not clear, some of the things we're missing, some of the things that we should be doing better, And one of the themes that emerged, which Dr. Lim alluded to in her talk, is the importance of good data and the importance of data that, clinical data, how the patient is doing, what kind of response, what kind of blood work, and so on. What's the timing of that, what kind of treatment the patient is getting. And that kind of information to be matched to biological samples, a skin biopsy, a blood test done at the same time, and that's what annotated means. Annotated samples mean that I have a skin biopsy in my tissue bank taken on December 1st. Now, I also know that the patient on December 1st was in remission and he was being treated with targretin. Unless you have that information, that biopsy is, I'm not saying useless, but certainly is not as helpful as it could be. In the past, a lot of the biology was being done on so-called, unidentified samples. So in other words, a researcher in the laboratory, like Dr. Lim, for example, would have a very interesting new gene to study or new protein to study, and she would need 100 cases of MF. She would go around the country, request, tissue banks, and a tissue bank comes up and say, okay, I have 100 cases of MF. You can look at them, and you see that they're MF, and I'm going to send them to you, and Dr. Lim would look at that. The problem is that, there will be no one would know anything about those patients. I mean, were those patients being treated with something? It's almost impossible to get that information. So if we really want to make some progress, it's key that we acquire the biological information at the same time as the clinical information. The only way to do that is to be sort of followed, or at least, not necessarily seen all the time, but to be followed on a regular basis by a research center. And in the U.S., most of the research centers are these large, National Cancer Institute funded cancer centers where there is enough resources, enough information and expertise that all that information is collected. Now, this requires participating in research, which means spending more time in the doctor's office, signing a bunch of papers and, and being available, for example, to have an extra skin biopsy that I'm sure you're not looking forward to have. No one likes to have, any biopsy or skin biopsy are the same. But if we are to make progress, a lot of progress has been made thanks to the work that Dr. Lim, for example, has done. But if we really want to go to the next level, kind of the quantum leap, and really kind of get rid of this thing, we have to do it that way. There's no other way. So I would encourage you, you may be followed, for example, by your doctor, by your local doctor perhaps. I would encourage you to say, okay, what's the closest CTCL research center that we have right here? How can I help? What can I do? And the Cutaneous Lymphoma Foundation can help you with that. That's the one good thing that, one of the good things that they do. We need your help to help you. And without that, I think, not to say that we're not going to make any progress, but the progress is going to be slow. So we really need to have as many samples as possible, blood, skin, clinical information, your data being entered in a registry, in a database. Some people don't like that, but I think without it, there's no way to make any progress. So I don't know if anyone else has anything to add.
Well, I have to agree with those comments, and one specific question that I think comes up from the discussions and questions from the audience is we can make diagnoses of patients who have early stage mycosis fungoides, but clearly some of those patients behave differently than others. And so we need to come up with a better way of predicting the behavior of mycosis fungoides patients who present at stage 1, A and B. And I think that's probably one of the major efforts that should be pursued in the future. And to do that, we need to really focus on getting characterized samples.
I totally agree. That's a great point, Megan. So, and here is also to expand on that. Think about this. Generally, people start thinking about research when things are not going too well, right? I mean, clinical trial, research, and okay, then if things are going well, things are easy, then why should I waste my time doing this and why should I do that? Well, what Dr. Lim is saying that actually when you're doing well, that's exactly the right time to start thinking about research. And that is true also on the doctor side, because the doctors often, unless they're really working in a cancer center, it's easy enough to give you some triamcinolone or clobetasol to put on the skin, and you do well, and so why should you worry about anything more than that? But that's the key. We need to figure out what fraction of patients who are doing well and they have early stages. Fortunately it's a small, but it's a sizable fraction of those patients eventually over 10 years, 15 years, they will progress to more advanced stage. Those are the patients that we have to identify early on. The only way to identify them is to actually have information, have biopsies, have samples and information. If we wait until they move on to stage 2, that's too late. We don't have any information. So I think that this is what you should, if you talk in the listserv to talk to other patients who have the disease, that's a message that you have to disseminate. We need really to start looking at the disease across the whole spectrum, not just focus on things when things are not going well.
I have a new granddaughter who was born last July with neuroblastoma. And I had the opportunity as such, and I call it an opportunity, to learn a lot about that disease. And I was fascinated that they have, and I can't remember whether it's a consortium or whatever it is, but all of the major centers around the country that are treating neuroblastoma feed their data into that center, that there seems to be a significant amount of control and data sharing and information sharing and strategic thinking that comes from that. As the head of the U.S. CLC, do you envision that you'll be considering setting something like that up for CTCL?
Thanks. Sure. In fact, not only we're considering, but we're doing it. Absolutely. So I would say the emphasis, the resources also to do that, to develop the infrastructure, and the focus and the programmatic thinking behind it, and actually even the political work to sort of bring everybody on board, that really matured over the past 2 or 3 years. So the good news is that we're definitely moving in that direction. There are several benchmarks that have already been met and passed. There will be a registry in the U.S. Through the USCLC. We are already kind of collecting the funds to do it, the early work. I would say that by the end of the year, we should have the registry up and running. Not only that, but also internationally, the U.S. registry is going to feed and overlap with other national registries from the UK, from Europe. There's an organization called EORTC, which does most of the cancer research in Europe. So this is an international effort that is going to feed, from multiple centers, actually have a centralized data management. For the U.S., the centralized data management is going to be at Duke University. For the international effort, the centralized data management most likely is going to be at Stanford. So I agree with you. I mean, that's, the only way to really kind of move forward, in addition to some of the things that we discussed, is for a coordinated teamwork. And that is happening. So.
Yeah, and I'll also add to that as part of the USCLC registry and the international efforts, we, as the Cutaneous Lymphoma Foundation, are also included in that. So we'll be informing sort of the patient piece of that. And then the foundation also has on the horizon of doing a patient-oriented effort that will be able to capture not necessarily the clinical data, but I think if all of us have talked about, we probably had the disease way before we were ever diagnosed. So to be able to gather some of that interesting information across all patients, no matter where they are internationally, to gather some of that trending and to see if we might be able to come up with some interesting things across the board that we can then go back and share with the clinicians and say, wow, have you ever thought of studying this particular, or we seem to have people in this geography that have had the disease for a longer period of time, or, you know, we say that the disease occurs in older people, but you know what? If you really talk to folks, everybody's had it for 10, 20 years if they really go back and think about it. So then are there markers that we can start to look at early on that we can get and understand the diagnosis sooner and then the treatment? So it's all part of the community, and we're all collaborating, which from my perspective as a long-term patient is, I think, amazing that we as patients have a voice in the process, and we're collaborating with the clinicians who are doing all the wizard science behind the scenes. So it's pretty exciting, I think.
Hi, my name is Martin Bromley. My disclaimer is I work for Theracos, but I was a bone marrow transplant and oncology nurse for several years prior to joining the industry. And I wondered, and this is a good lead off of the discussion, is how can industry partner with you guys to get the word out? Let's say there is, you know, the registry, and you guys have a program for accepting samples and information or identifying patients at initial diagnosis. You know, how can we help you get the word out? Let's say there is a way to do that, because there's obviously a lot of sales reps who are going into community, you know, dermatology centers or talking to non-specialists in CTCL. And I just think this would be a great opportunity for us to help you increase the speed at which data is collected.
Absolutely, and I think that industry is really already helping quite a bit, because of course when we talked about, you know, the development of this infrastructure requires resources and funding, and, you know, very substantial funding, and you know, over the past year and a half, we've been able to gather a significant amount of funds and commitments to fund from pretty much across the spectrum of the corporate world involved in CTCL. So, you know, including your company. So, you know, I think that is good. What to do at the grassroots level, which I think seems to be the question that you have, is it's a little more difficult because just of sometimes the limitations of the interaction between the marketing, you know, there are some, of course, right, some firewalls that you have to follow and so on. I think that, you know, what you're doing right now, supporting this kind of program right here and supporting the foundation, I think it's a very important way of getting the word out for sure among the patients, and then all the support that we're getting as an organization, you know, as the USCLC in general, and then for the registry specifically, I think that clearly that is very supportive. Once, you know, the registry is up and running, I'm sure that we can come up with a variety of different initiatives to sort of, you know, disseminate the word and include. So, but thanks, that's a good point.
I have a comment and a question. From my own experience, I think it would be helpful somehow to get the word out to dermatologists and regular physicians that if a person has such a skin condition and you treat it and it keeps persisting, that biopsies should be done. Because for me, you know, I treated myself, then my regular doctor treated me for a year or so, and it didn't go away, sent me to a dermatologist who said, oh, it's eczema, you know, you take this cream or ointment, and you're going to have it your whole life, so don't bother coming back. If it, keeps coming back, that's the way it's going to be. So I struggled on for several years, and then suddenly it got much worse. It turned into the plaques. And luckily my insurance had changed, so I got sent to a different dermatologist who believed in biopsies. And she gave me a biopsy, and then I had to have second ones for the cell studies or whatever to find out exactly. And then I was referred to Henry Ford Hospital and started the treatments. But that took the 10 whole years of fooling around, and if I'd had a biopsy earlier, maybe I could have, avoided progressing, to like this stage 2A. I was sort of between A and B, whatever, when I started. Now, the other thing, I went through several different treatments. Dr. Wong was one of my doctors. But eventually, the nitrogen mustard, by doing a double dosage, has put me in remission, and I have had nothing for around 28 months. So my question regards remission, that how long can a person expect it to last? Because every time I get a little itchy spot, I quickly pull out my clobetasol and start treating it, whatever, because, you're kind of paranoid about this. So, it could be just this winter dry skin or something.
Yes, that's, well, I think, you have 2 points. One, I think in terms of patients getting biopsy early, I agree. I mean, to make a diagnosis early, patients do need to have biopsy on a regular basis. Your story is, when we teach residents, is not so uncommon. I think the textbooks in the past says, sometimes it takes 8 years of repeated biopsies even every year to have a diagnosis. So you're not alone. So that's one. I think the important thing is that I think for those who do have the disease, I guess in your case you had thicker plaques, and I would just say, well, we would have, it shouldn't have taken that long to make the diagnosis. But I think your story, part of it is very typical, and that is something I think the story is important to share, and I think that's where I think the CLF can really share the story and help other patients, and so that we can get patients a little more involved, and because sometimes patients don't want to do a biopsies, and then when that's the case, the physicians won't as well. But I think it's important to do biopsies. In terms of your, I'm really pleased that you are doing so well, I think, and that's great. We're all very happy, and there, I think, we don't, everyone is different. I think some patients, we don't know what, cure or complete clinical remission is. And even in some of the studies where, we do repeated biopsies, it all depends on sampling. So repeated biopsies, the role of that is unclear. I think your concern and what it tells me is that I think, even though there's nothing on your skin, you still have some symptoms. I would say then that it's important that you you are monitored by somebody who is an expert in CTCL, and I think, and that's not unreasonable. I mean, even when in our multidisciplinary clinic with Dr. Porcu, I mean, rarely I think we say, I mean, unless patients are from very far away, we say, well, you come back as you need it, but often we have patients come back once a year just to monitor. Sometimes, a lot of times, thank goodness this disease for a lot of patients, there's not a whole lot, they're not involved, and, they're happy, we're happy, but we like those visits as well. So it's not unreasonable to have that.
To your point about letting the local dermatologists and regular physicians know, that's one of the reasons we decided to establish our new advocacy ambassador program, so that all of us as patients in our local community, if there's a health fair or if there's some other kind of event where we can have a little table and let people know, or let folks take information to their local dermatologist or their general practitioner, just to educate and let them know about the disease, so that there's a little more awareness, so that we can get out there and let others know about this disease, and that where they can go to get the expert referrals and help and things like that. So we're hoping to be able to do that and create our own kind of grassroots core of ambassadors out there that are letting folks know, because as our organization with 5 people, we can't get out there to everybody, but you all are in the communities. And so if we can collaborate with you and have you work on behalf of all of us to get the word out there, I think that'll help the awareness, and then to get people diagnosed faster and connected to the right people at the right time.
Just one quick question. Since it seems like there are not a lot of experts in the field, do you think that it's possible that the percentage of MF patients is actually higher? And the second part, do you think that lifestyle has an impact on your symptoms, like stress?
So I think that, and these are very indirect, it's more of a guess than a real knowledge, but I think the feeling among most of the doctors who follow CTCL on a regular basis is that there are probably a significant number of undiagnosed cases at any given time. And in regard to the number of experts, I'm optimistic about that, because I think that there seems to be an increase in the interest among physicians, and even now among hematology young hematology doctors who are getting trained. CTCL typically was not one of the things that they were getting interested in. Now, thanks to the foundation, for example, now they've been starting to fund these travel grants. It's called the Young Investigator Award. In the past, it used to be only to dermatology meetings. For several years now, the foundation has funded travel grants to hematology meetings. So, even hematologists can get involved a little earlier on. So I think there's a lot of good effort going on, and I think that some of the results, we will see them. It just takes a long time. And to go back to perhaps what your question was about, a little more awareness. My impression, not knowledge, but my impression is that the younger generations of dermatologists are much more attuned to this problem than the older generation of dermatologists or oncologists. And so, obviously we're going to see the difference, 10 years from now, I guess. But I think things are changing. Regarding the lifestyle, there's really nothing specific. The only thing we know is that exposure to sunlight often actually relieves the symptoms and even makes the skin look better. I mean, we have patients who come to see us, and the disease gets worse in the winter and gets better in the summer. I mean, we had a patient, actually, Dr. Wong and I, that she was working as a lifeguard at the swimming pool, and the summer was fantastic, and she was going in remission every summer, and then the disease was coming back in the winter. So, but there's nothing else, as far as diet or lifestyle specific that we know of that has an impact on the disease.
I do have just a brief question. I think I've had the symptoms of this for 40 years now. I've been treating with a dermatologist for 15. The question is, the condition, I would say I'm a 1A. I'm very, very light plaques, but they're there, and they come, they go, they come, they go. I can treat them to keep them away. I can self-medicate with a chemo drug right now to reduce the appearance. Should a patient manage the disease to keep it as minimal as possible to increase longevity, or is it sort of one of those things, unless it starts getting to higher stages, it's nothing you're really going to have much effect on longevity? So.
The fact is that we don't know, number one. And we don't know because the only way to know is to actually do some kind of a well-designed prospective study. I think that one of the things that could be done is sort of look at the intensity and different treatment styles, if you want, in different populations, and see whether that makes a difference. There are some very practical and even scientific reasons why those kind of studies would be very difficult to do. Because to be able to, there are some statistics behind it, and to be able to really draw any kind of conclusions, you need to have a certain number of, we call them events, within a certain reasonable amount of time, because otherwise, we could be starting a study that then, we're all going to be retired by the time we figure out whether it worked or not. And typically, doctors, they like to get things done a little faster because they need to get promoted. So if you, my boss would say, don't do a study that is going to figure out, it's going to take 20 years to figure out. So those are some of the practical things, right? There's a great questions. I think they're important questions, but we just don't know. I guess, more of an impression level, impressionistic level, I would say that if you have recalcitrant spots that you can keep under control with something acceptable, some topical, I guess most of us would probably say try, right, to keep it, especially if you see. So I think that at a very general level, I think we would be more inclined to say try to keep it under control as opposed to not to.
Right. From seeing a lot of patients, there's certainly, this is a very heterogeneous disease. There are, we do see patients who come in. I've had, who are 50s and say, well, I've had this rash since I was 20s. So there is, this is an indolent disease with a wide spectrum of progression. But the data does show that there, a certain percent does progress. Now, we just don't know. Right, these studies to try to tease that out is going to be very hard. And in for you, you wouldn't want to be the one who is left alone and progressed. And so, I think in terms of a practical approach, treating patients, and it sounds like your lesions come and go. Well, the fact that if they get a little more sort of, angry looking, then those in general are the types of patients we would prefer. Actually, we can control the disease, make sure, we define it by making sure it doesn't spread to be more extensive than it is on the body surface area, but also, we want to make sure that it isn't more symptomatic. So, those are some of the signs we use to monitor our patients. So I think, if possible, control it and have it to a minimal degree. But if it's just a little bit, we do, accept that it's, patients can have that. And as long as it doesn't change, then that patient's disease is biologically more indolent, and that's okay.
Thank you all so much for your time and your energy and your information and for your hard work.